You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is April 18, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, complement disorders. Our presenter is Dr. Belinda Graham. She's an allergy immunology fellow at Children's Mercy Hospitals and Clinics.
I'm your host, Dr. Jay Portnoy, and I've got a cold. It's not allergies. Even though it's allergy season, sometimes you can get colds and allergies, and when you get both of those, it becomes a real problem. Actually, either one can be a problem. But be that as it may, we're not going to talk about allergies today. We're going to talk about another part of the immune system, and that is complement disorders. This is one of those topics that always has confused me because there's so many different components to it, and they keep increasing the number of components to it every year that I hear about it. So I'm sure that I'll learn something new. I learn something new every time I hear it. We're very fortunate today to be joined by Dr. Belinda Graham. Dr. Graham is one of our second-year allergy immunology fellows, and she's going to lead us through a discussion of complement disorders. So without any further delay, we turn the keyboard and podium over to Dr. Belinda Graham.
Okay, thanks, Dr. Portnoy.
You have to activate.
Yeah.
Oh.
Okay. I do. Okay, and I just go up and down.
You go forward and down.
Okay. All right, I have no disclosures at this time. And the objective to my presentation is that we will learn about the clinical manifestations of complement deficiency, that we'll learn appropriate screening or necessary laboratory assessment, and that we will learn proper management for specific complement deficiency disorders. And so I have four pre-test questions. This is the first one. What is the most commonly identified human complement deficiency? Which deficiency of the alternative pathway is X-linked and not autosomal recessive? Factor B, Factor D deficiency, Proferdin deficiency, or all the above? Which deficiencies are most commonly associated with SLE? Early classical pathway complement deficiencies, which is C1Q, C1R, C1S, C4, and C2. Terminal complement components, which is C5 through 9, factors CD55 and CD59, A and C are all the above. And last but not least, these deficiencies have been known to be associated with serial infections, factor H, I, G, D, Proferdin, terminal complement components, and then I have combinations of A, B, and F, C, D, E, and F, or all the above.
Well, you don't make it easy, do you?
Any choice. All right. So I'm not gonna go through the pathophysiology in this lecture so much, but I will do a brief overview of the complement system just so some of the disorders will make more sense. And so the complement system is an effective mechanism that involves both the innate and humoral immunity. The function is to promote phagocytosis of microbes, to stimulate inflammation, and to induce lysis of organisms, which is the MAC complex of the terminal complement component. It's classified as inherited and acquired, and what I'll be discussing mainly are the inherited complement deficiencies, but I will mention a few of the acquired. In the lecture before, you learned about some of the acquired ones. So with the inherited complement system, there's three pathways: classical, alternative, and elective pathway. All these pathways differ in how they're initiated, but all result in the generation of enzyme complexes that cleave complement protein C3. So that's the one component that's common to all the pathways. This process generates active products, and then eventually C3b attaches to microbial cell surfaces or the antibodies that are bound to antigens. So with the classical pathway, it's activated by antibodies binding to antigen. This is the first pathway to be discovered and characterized, and this is a major component of adaptive humoral immunity. With the alternative pathway, antibody is not involved, and this activated directly on the microbial cell surfaces. This is actually the oldest pathway, although it wasn't discovered first, and this is a component of innate immunity. And with the lectin pathway, it's activated by plasma lectin that binds to mannose residues on microbes, and it's also a component of innate immunity. So complement deficiency are infrequent in patients with recurrent sinopulmonary infections. So oftentimes we get referrals to rule out immunodeficiency in patients that have recurrent sinopulmonary infection, but it's uncommon that you actually find a complement deficiency in these patients. However, you would suspect a complement disorder if you do get a referral with someone that has recurrent sepsis, systemic infections, those that have sepsis with a history of autoimmune disease, or those with sepsis that have a family history of autoimmune disease. So actually the classical and alternative pathways deficiencies are actually rare, and it's less than 1% of patients with primary immune deficiency. NBL deficiency is actually fairly common, 3% of the general population, but these people can be asymptomatic and not necessarily know they have this deficiency.
Would they get like recurrent candida infections, thrush, that kind of stuff?
It is thought with NBL that they can get the strep and H flu and things like that, but it's thought, and I'll talk about this later, that with NBL it's more of a cofactor issue. So it may not be causing the infections more. It may be if you're already having an infection, you're going to be more likely to be sick and have recurrent problems. So it's a synergistic type of phenomenon that's thought to go with NBL.
Okay.
So the majority of complement deficiencies are autosomal recessive. The exception here is the proparative deficiency, which is X-linked. Most deficiencies, the males and females are equally effective, except for, again, proparative is going to have males, which is X-linked. And the majority have no definitive racial patterns. However, I'll mention later on that there's some deficiencies that where certain ethnicities are more likely to have the defects. So the first one I'll mention is C1q deficiency. This is the autosomal recessive deficiency. You have compromised opsonization, and you actually have a mild decrease in B-cell co-stimulation. And as a result, you're going to have an increased risk of infection. And with this one, you're going to have more severe disease than some of the others. With this one, you're also going to have an early age onset of systemic lupus. With these patients with lupus, you're going to have more dramatic cutaneous and CNS manifestations. And as far as the antibody profile, you will less likely see anti-double-stranded DNA antibodies with this one. Another one of the classical pathway is the C1R/C1S. This is another autosomal recessive. This is very uncommon. Because these are linked, if one is unstable, the other one's unstable, so they kind of live together. And so if you have a low level of R, you're going to have a low level of S. With this one, you're going to have a high incidence of vasculitis. So again, you're going to see things like glomerulonephritis and lupus. Another one with the classical pathway is C4 deficiency, which you've all heard of. This can be acquired or autosomal recessive. With this one, you're going to have impaired opsonization. Again, you're going to have compromised B-cell response to antigens and increased risk of infection. And so with C4 deficiencies, this is going to be the major cause of death. With C4 deficiency, you can have partial as well as complete deficiency. The partial deficiency is very common. It's going to be associated with lupus. The complete deficiency is rare. You're going to have early onset lupus. But with this, you actually have mild renal disease. Cutaneous manifestations are more common and severe. And again, with this type, you may not have anti-double-stranded DNA antibodies as you would with more other forms of lupus. C2 deficiency is autosomal recessive. This is the most common human complement deficiency. It's more common in Caucasians. Most people are asymptomatic. Again, you have increased risk of infection, and the most common cause of death is sepsis. 20 to 40% of those with this deficiency develop lupus. Now, the ones I just mentioned before, the C1, 2, 4, those are all common to the classical pathway. But actually, C3 is common to all pathways, if you remember. This is autosomal recessive. It's the rarest of the 4 early components that I just mentioned. With this deficiency, you have loss of optimization, loss of cell co-stimulation, and loss of immune complex solubilization. This is actually the most severe of the complement deficiencies, as it would make sense because it's linked to all the pathways. And so with this one, you're going to see profound infections such as abscesses, sinopulmonary disease, sepsis, as well as meningitis. You're going to also see membranoproliferative glomerulonephritis instead of lupus in a third of cases. And because of the issues with making immune complexes more soluble, you may see a vasculitic rash and severe sickness as well. And so the third category are the alternative pathway deficiencies. Factor B deficiency is autosomal recessive. You have an increased risk of infection. It was discovered because it was discovered through a single case report. It was discovered after patients developed meningococcal disease and was found to have 0 AH50, which is how you screen for deficiencies of the alternative pathway. And if you remember, factor B is in the alternative pathway is a component that actually binds to C3. And once that's cleaved, that turns into big B, little b, just to refresh your memory. With factor D, that's autosomal recessive. And factor D is the thing that actually cleaves factor B so that you can get big B, little b in the alternative pathway. So based on what I said, you actually get almost no activation of alternative pathway because you don't have this cleaving mechanism. Nosocomial infections are the most common manifestation, like you would see with a factor B deficiency. With this one, you also have systemic strep infections also.
Is that what you had on the other one?
It was
meningococcal.
Yeah, both of them are meningococcal. And another component of the alternative pathway is the properidine deficiency. This is the only X-linked complement deficiency. It's seen mostly in Caucasians. This component is necessary for C3 convertase, which is the C3 big B, little b, and C3b. That's what stabilizes that whole convertase so the pathway can even get started. So once again, activation pathway is impaired, and you can't get beyond that point without the stabilization from this factor. Again, as with the other two components of the alternative pathway, you have meningococcal infections, but you can also see less common bacterial infections. With this one, which I didn't know, you have a high fatality rate of meningococcal, and this is less likely in terminal complement deficiencies. You always hear about meningitis with the terminal complement deficiencies, but with this deficiency, you actually have a higher fatality rate from that disease. You may...
Well, CH50 wouldn't pick this up, would it?
PED and properidine, AH50.
Well,
you have to do AH50.
Right, because the thing is, when somebody comes in with a meningococcal infection, we always recommend that you do a CH50,
Right.
but we need to be telling people to do AH50s also.
Exactly. You're absolutely right. You have to do both.
Okay.
Discoid lupus and dermal vasculitis has also been seen in this disorder. So moving on to our third pathway, lectin pathway deficiencies. Mendel binding lectin deficiency is an autosomal disorder. It's common. It's a common disorder. You have increased risk of infection, sepsis. There's also been evidence of tuberculosis seen in these patients. In prior studies, there have been some conflicting evidence. Some have shown increased association with upper respiratory tract infections in children, and some have shown actual decreased association. The interesting thing I learned about this is that with this deficiency, it may modify disease susceptibility, but on its own, it may contribute minimally to the susceptibility of infections. For example, a burn patient may already be susceptible to some pseudomonas, but if you have MBL deficiency, you may have more of a poor prognosis or more severe infections. Does that make sense? You were asking about that earlier.
So isn't there a test here, the IVT test or something like that?
Yeah.
Serum concentration. Okay, it's just the serum concentration of MBL.
Yeah. You also may have increased risk of lupus, but it's, again, protected for renal disease, so the renal disease is not severe in this population. And something else I didn't know, that it can be more prevalent in those with Crohn's disease. So I'll briefly go through the terminal complement deficiencies. They're pretty much all the same, C5 through
Protected
C9.
for renal disease.
I know.
That's interesting.
So they'll have lupus, but kidney manifestations won't be as profound.
Because you're not making as much inflammation due to the complement deficiency.
And so the
other complement deficiencies increase risk of autoimmune disease.
Right, but the autoimmune disease that you get tends to be less severe because you can't make as much inflammation due to the complement deficiency. So the reason you get that is because there's a linkage disequilibrium.
And then with some of the complements are, remember I was saying they solubilize the immune complexes. So if you can't phagocytosine, you can't solubilize it, then they stay around, and then that causes the inflammation too. It causes the kidney problems. So that's another issue that goes along with complement deficiency. So I split out C5 through C9 because there are some minor differences between them, so I'll just briefly go through them, but most of these will be the same. C5 deficiency is autosomal recessive. You'll see serial infections, such as meningococcal and gonococcal disorders. With most of these that I'll mention, they do report some autoimmune disorders, but the way they state this is that it may represent ascertainment bias, which means you're already checking for complement, so is it a coincidence that you're finding these autoimmune disorders? And so they think it may just be because you're already assessing them that you may be picking up and causing bias in your results. C6 deficiency, autosomal recessive, this one is just like C5, but it's more likely to be seen in the African American population. Again, not serial infections with this one. C7, just like C5 and C6, except for C7 is more or less, it's actually less common than the others, but again, you see serial infections. C8, just like the others, you have serial infections, and you may see some autoimmune disorders. It's composed of alpha, beta, and gamma chains. And with C9, there's a high frequency of this deficiency in Japan and Korea. The interesting thing about C9 deficiency is that lytic activity can be generated in the absence of C9. So if you have a complete C9 deficiency, you will still have a value for your CH50. It could be 1/3 or half, of normal, but it won't be 0. And that's because you still can have lytic activity still going on here. So that's important to note that your value may not be 0 with this deficiency. Again, you may see some autoimmune disorders. And so the next category I'm going to talk about are actually regulatory protein deficiencies. And you learned a little bit about this in the prior lecture, factors I, factors H, and MCP. The first one, factor I deficiency, is autosomal recessive. what happens with this is that you get unregulated complement pathway. And so if it's not regulated, it's continuing to occur, and at the end of the day, you're actually consuming C3. And so again, you're back to the point of it looking just pretty much just like a C3 deficiency because the pathway is being unregulated. You're going to have increased risk of infection, Neisseria, Strep pneumo, as well as H. influenza. As you just learned a few moments ago, factor I deficiency is associated with atypical HUS. It's atypical in fact that you don't have an infectious cause, such as E. coli causing diarrhea associated with it. You may have a serum sickness-like picture, and you'll have membranoproliferative glomerulonephritis also associated with the factor I deficiency. Factor H is going to be similar. It's going to be unregulated complement pathway, and so again you're consuming C3, and so you're going to have an increased risk of infection. With this one, it's autosomal recessive as well as heterozygous mutation. Again, you have the atypical HUS and membranoproliferative glomerulonephritis. The thing that's different about this one is that there's a polymorphism of factor H that actually causes macular degeneration, and so that's going to be the difference between factor H and factor I deficiency.
And what are those associated with that nephritic factor thing, or maybe both of them?
Yeah, there may be one there. I'll check. And so the third one is membrane cofactor protein, which is CD46 deficiency. This is intrinsic to the kidney. It's also autosomal recessive, and it's late onset HUS compared to factor H and factor I. So basically with factor I, you're going to have atypical HUS, membranoproliferative glomerulonephritis. Same thing with factor H, except for you're going to have the macular degeneration. With MCP, you're going to have the same thing, except for you're going to have a late onset HUS. So you have to kind of tease out the major differences between the two because a lot of these are similar. Another regulatory protein deficiency is C1 inhibitor deficiency. I know you all are experts on this now, and so I won't go into it a lot, but I'll just mention a few things. It could be autosomal dominant or acquired, associated with hereditary angioedema. You actually may have a mild risk of infection with this, and you can have an increased risk of SLE because of C2 and C4 consumption. Other regulatory protein deficiency, CD55, which is DAF, and CD59 deficiency is responsible for paroxysmal nocturnal hemoglobinuria. With this disorder, you have an acquired somatic mutation of PIG-A or PIG-M in progenitor cells, and because of this mutation, you don't get the expression of CD55 and CD59, which are GPI anchored proteins. So without having these proteins on the surface, you cannot protect red blood cells from complement lysis. So you have to have those things to prevent lysis of red blood cells. So it's actually a protective mechanism.
Because the red cells suck up a lot. I mean, they're like a sponge that sucks up immune complexes and complement. And I guess the good question is, well, why doesn't the complement lyse them when it's sucking it up? This is what does it.
Right. You have to have those things there, have those things present to protect the cell. And so the manifestations of this are intravascular hemolysis, which makes sense. You're having lysis of the cell. You're going to have hemoglobinuria as a result. You also have venous thrombosis, and most of the text says they're not really sure why that occurs, but that goes with the clinical presentation. And you also have deficient hematopoiesis and can get aplastic anemia as a result. And another category are complement receptor deficiencies. CR1 deficiency is acquired disorder, and a lot of these receptor deficiencies are responsible for clearing immune complexes, and this is no different. And so you have impaired clearance of immune complexes, and as a result, you have immune complex disorders and serum sickness. This deficiency you're all familiar with, CR3, CR4. This is a defect in beta-2 integrin. As a result, you have ineffective optimization. Neutrophils are unable to transverse vascular endothelium to actually phagocytose bacteria. Beta-2 integrins are essential for firm adhesion step and diapedesis. And so this is essentially LAD. That's the more common term for this. Clinical manifestations are elevated resting WBC count, necrotic skin infections without pus formation, delayed separation of umbilical cord, and bacterial and fungal infections. So you guys already know about this one. So as far as what Middleton talked about as far as how to determine laboratory assessment, those with a single meningococcal infection in a non-endemic area probably deserves an evaluation. And so you want to do CH50 and AH50, like you said, Dr. Portnoy, because, as you know, Neisseria can be involved in both pathways. CH50 and AH50 should also be obtained in those with meningococcal disease if they have an unusual serotype, such as XYZ, W135, or 29E. If you have the disease and there's a family history of it, you want to obtain this lab. And also, if you have recurrent disease, you want to obtain this.
I would just obtain it in the first infection. Don't wait for the
and
recurrence.
That's an option too.
But can you order an AH50 here at Children's Mercy?
They used to be sent out to National Jewish. I don't know what they are anymore. Because they're so rarely ordered, I doubt that they have them here. But they
We
do it
don't
here.
see a lot of Neisseria.
I mean, when Belinda was talking, we had a patient when Dr. Lipoli was here that I remember that we went through this process with, and I probably can count on one hand the number of times that I've been involved personally in one of these cases since I've been here. So they're not very common, I don't think, at least for us seeing them. They may be.
My guess is that.
Pardon me? I don't think we get comparable on them.
No, yeah, I don't know how.
My guess is that the incidence is pretty low, and part of that is because of the vaccines. That, I mean, since everybody who goes to college is getting vaccines now, the number of people who carry it has probably decreased a great deal because of herd immunity, and so it's just not prevalent in the population. So these kids with these complement deficiencies may not be being detected because they're not getting infected by the organisms, just not around.
And I mean, when you and I were residents, it wasn't that uncommon to see these kids come in, and you know, you just don't hear
You
that.
used to see it all the time. Yeah.
You just don't hear about very much anymore.
Yeah. Vaccines work, don't they?
And I was trying to figure out of all the gram-negative bacteria, why Neisseria and why not some of the others. And one of the texts that I saw said that Neisseria has a thinner wall, and so it's not as protective. It can't protect itself against complement like some of the other gram-negative bacteria. So I always wondered why the prevalence of this particular bacterium. Okay. You also want to get a CH50 assay if there's someone that has severe lupus with an early age of onset. Those with the C1 and C4 deficiencies can present this way. Also, if there's someone that's lupus and their autoantibodies are negative, then you want to think about checking a complement assay in these patients.
My guess is the rheumatologists do this anyway.
All with atypical HUS should be evaluated. You want to get a CH50, AH50, and C3 level. If these are normal, you want to get factor H, factor I, and MCP, as we mentioned before. Those with membranoproliferative glomerulonephritis type 2 should be evaluated if there's suspicion for complement disorders or nephritic factor exists. So you want to evaluate for C1 inhibitor deficiency if there's recurrent angioedema in the absence of a trigger, with those with a family history or those with angioedema after trauma. As you all know, C4 level is a simple and sensitive screening, but C1 inhibitor level and C1 inhibitor function are the superior tests to pick up this disorder. So no specific replacement therapy really exists for any of these disorders except for hereditary angioedema. A lot of the management is depending on identifying specific defects. With a few exceptions, there are no trials that really support the management strategies. There are some possible interventions based on current literature. So I'm saying all this to say is that we're still trying to figure out how to treat these patients. So with the early classical component deficiencies, you treat the lupus patients the same as you treat those without a complement deficiency. There's been one European study that showed C2 replacement was helpful, but this is not widely available. You want to vaccinate these patients to raise antibody titers to encapsulated organisms, and you want to also consider antibiotics for prophylaxis. As I mentioned before, because infections with C3 deficiency are so severe and you have the loss of optimization and B-cell co-stimulation and you have issues with immune complexes, these are things you want to target when you're treating these patients. So you want to consider IVIG and prophylactic antibiotics in these patients, and you also want to consider renal transplant with those with end-stage renal disease.
Of course, if you have a C3 deficiency, how would the IVIG help? Because you don't have complement to work with the antibodies, so you're giving. The problem isn't an antibody deficiency.
Yeah.
I mean, you almost need like a liver transplant or something. Yeah. That's probably the solution.
As I mentioned before with MBL, it's not really known what fraction of these have significant infections, but the number is suspected to be low. If there are cofactors that synergize with MBL deficiency leading to recurrent infections, then these cofactors need to be addressed. And also you want to consider prophylactic antibiotics in these patients as well.
We had a fellow candidate here a couple of years ago who was interested in finding lectin, and he presented an abstract at one of the meetings, and I remember looking at it, and it was based on some data from the Europeans, but apparently the Europeans, he was doing screening, but I said, well, when you find this, what do you do with these patients? And he had some data from the Europeans that for a while at least they were giving replacement therapy. I'm not sure how they came about it, but they replacement therapy, but it got taken off the market for some reason. But it was, as I recall, it had to be given. It had a very short half-life. It had to be given like 3 times a week or something, some frequent period. So, anyways, it was kind of interesting that because that test has been available from IBT probably 10 years, and it's like you get it, but what do you do with it, sort of thing. So it was interesting that even at some point someone was even trying to come up with some replacement therapy. So.
With terminal complement deficiency, vaccination every 3 years for meningococcal infections decreases the frequency of episodes but does not eliminate it, and it decreases by 20%. No studies have examined prophylactic antibiotics. So that's where the term hypervaccination comes from. With factor H and I deficiencies, you treat these the same as you would those with terminal complement deficiencies. And those with HUS have received plasmapheresis and FFP, as you learned in the prior lecture. In one study, their factor H replacement was shown to be beneficial. Renal transplant is not recommended for end-stage renal disease because of the high recurrence rates. I think you heard before in the earlier lecture, it was like a question mark. He was like, you know, some transplants, some don't.
At the same time. Yeah.
Right.
Well,
right.
Unless you fix the underlying problem that caused the problem.
And so this is an issue for these. With MCP deficiency, it's less clear if pheresis and FFP is helpful. Pheresis may help clear inciting agents or complement activation products. With this one, renal transplant in those with end-stage renal disease may be an option because the renal disease typically does not reoccur. So with H and I, factor H and I, a lot of times it recurs, but those with MCP usually do better with the transplant. I won't go into all the treatments, but I'll just mention for C1 inhibitor deficiency, you have short-term prophylaxis, long-term prophylaxis, acute therapy. You want to make sure your patients have medical alert bracelets. You want to do genetic counseling, and you want to have them avoid ACE inhibitors and estrogen-containing medications to prevent angioedema.
Oh, yeah.
So, did you have a question about that?
No.
You sure?
Yeah.
Okay. So in summary, with early component classical pathways, which is C1Q, C1R, S, C4, and C2, you're going to have recurrent infections and autoimmune disease. With the late component classical pathways, that's going to be C5 through C9. You're going to see nocturnal infections. Effective screening for classical pathway is CH50. Complete deficiency is important to note that complete deficiency should yield low or undetectable CH50, except for I mentioned before in C9 deficiency you may actually have detectable numbers. And also heterozygous deficiencies typically have normal CH50, but in partial CH2 deficiency you'll have a zero CH50 number. So those are kind of the two that go against the norm when you're trying to evaluate. Paparidin is the only X-linked deficiency, and you'll see in the serial infections. AH50 is the way you screen for those patients. MBL deficiency is a common disorder. It may modify disease susceptibility more so than cause disease. C3 deficiency is common to all pathways. This is the most severe of the deficiencies. You're going to have severe and frequent pyogenic infections, and you also have glomerulonephritis present as well. Deficiencies in complement inhibitors such as factor H, I, and MCP, as I mentioned before, predisposes people to atypical HUS. And the difference with factor H is that you'll have macular degeneration in these patients. And it's important to note that management involves education of the patient, placing emphasis on early signs of infections. You want to take home that hybrid vaccinations are important against protecting against these serious disorders, and you also want to consider antibiotic prophylaxis in these patients. And so I guess I have the answer there. I know you all got it right. The most commonly identified human complement deficiency is C2. I know Rodney knew this one. The deficiency of the alternative pathway that is X-linked and not autosomal recessive is paparidin deficiency. And the deficiency that's most commonly associated with lupus are going to be all the early pathway disorders. With the second one, you're going to see nocturnal infections. With the third one, I didn't put it up there before because I didn't want you guys to know, but CD55 is the same as DAF, and CD55 and CD59 are associated with PNH. And with the last one, all of these are associated with nocturnal infections. But if you remember, the alternative pathways associated with nocturnal infections, as well as those are the terminal complement components. And so, as a result, all of these are associated with nocturnal infections.
G and H are also right.
Well,
choose the best.
They're hard questions to answer. We won't nitpick that. I guess my question is, in terms of management, these are obviously rare patients, but as we start doing genome sequencing, we're going to probably start identifying more of these patients because there's probably a lot of people who come in with infections, and we don't order AH50s and paparidin levels and stuff like that on kids who come in with sinus infections. We just treat them with sinus infections. And so I suspect we're going to start seeing a lot more of these patients now that we're going to be able to start sequencing their genes for these different proteins, which is going to be a much more efficient way of identifying them than measuring each of these individual proteins one at a time, which is a terrible way to do it, right? It's what we've had up until now. How are we going to manage these patients once we know that they have it? Has anyone looked at doing like a liver transplant to cure these conditions? Because most of these are produced in the liver. So if you could do a liver transplant, you could theoretically cure disease.
Then, which is worse? You're taking isosporin and MMF for the rest of your life.
Depends on how severe it is. Having renal failure and needing new kidneys, you're going to need it anyway.
What about just replacing the complement protein like we do with doing temporary or dedicated creatine that maybe?
Well, there's like one or two cases, like, of course, European stuff is always before. But anyway, there's been a couple of cases where they have, like, tried to replace factor H or whatever, and they said, oh, it's, it worked, but that'd be like one case.
Like 10 people.
Well, the thing is, if you replace the kidneys, then you still have the same defects, so you're still susceptible to the same infections. You're just going to build this by yourself.
So as long as you're replacing the kidneys, you might as well put a little bit of liver in also, and then that'll keep the kidneys from dying off. So maybe you'll be able to preserve them better.
You're talking about genome sequencing. Like, so many people have MBL and don't even know it, but I guess you're saying if we identify those patients,
they're going to want us to
treat
them.
Well, yeah, you can be more aggressive. Like when you know if they have an infection, we know it's a synergistic or kind of co-factor type of thing. If they get something, you got to be on top of it. If there's even a thought of infection, and then we have to be more aggressive. So I guess it would be helpful to know.
I've always believed that if you want to understand something as complicated as complement, somebody has to make a drug to treat it, and then they'll teach you all about it.
Yeah, right.
It certainly is true for hereditary angioedema.
Right.
If we ever got factor B or D or any of these other things as a drug, then we would learn all about that thing too. There'd be all these speaker programs.
So I have a question. When you are evaluating a patient like with recurrent secondary infections, you've got a CH50 that's low, what's going to be the next step in your laboratory workup? Are you going to start breaking down individual components of the classical pathway and ordering like C3, C4?
Yeah, you would start off like more broad, and then you would start like C3, as I mentioned before. That's one where you get like severe infections. That would be one. That would be one you want to check. So that's basically the whole thought, that you would start broad and then
go down.
But I think anymore we'll just do a primary immune deficiency gene array, chip array. You can actually just sequence all the genes and mass and see which one is abnormal. That's going to replace the need to order all these individual tests, which aren't widely available.
So this is an example of starting broad and then getting, so like if someone had atypical HUS, which I know you wouldn't be treating necessarily, you would start off with CH50, AH50, and C3, and then if that was normal and you still had a high suspicion, or if it's abnormal, then you get more.
Wouldn't it be nice to know that they had this before they got the HUS, so you could prevent the complications that occur from that? You had your hand up, Ron. Did you have a question?
I just kind of curious about the polymorphism factor H being involved in macular degeneration. How does that work?
It's actually, what I saw is actually, they keep saying a polymorphism. They just keep saying a polymorphism, and actually factor H.
Does the factor H actually cause it, or is it just linked to some other gene that causes it? That's what a polymorphism would tell you.
There's some sort
I don't know.
monoclonal antibody that they inject into the eye for a certain type of macular degeneration now.
I don't know.
I don't know if that has anything to do with it, but they
We
do
need to-
something and it's...
We need to learn about macular degeneration, which is caused by a low-grade inflammation, so maybe this complement component has something to do with it, but we're basically, we don't know.
One of the things that says that if you, like all the other complement deficiencies, if you're lacking it, then it's more of a protective measure. So remember I was saying with those, if you're missing that thing that checks the system, it'll keep going on and on and on and on. So if you don't have factor H, the complement system just keeps going, and as a result, you don't have protection towards what they call the choroidal vessels, and these in the endothelium get damaged, and as a result, they get this macular degeneration.
So you get a low-grade vasculitis in the macula,
Right.
because you don't have this factor H, which would be turning down the inflammation.
Exactly. So you're not checking the system, and as a result, you're getting damaged.
That makes sense.
Does that make sense, Todd?
Yeah, that makes good sense. Thank you.
You're welcome.
All right. Well, we're going to call it a day. Thank you all for joining us. This has been Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics. Join us again on Friday when we'll have more Conferences on Lyme Allergy. In the meantime, have a great week, and we'll see you next time.
It's weird, like factor H, I, and B.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.